Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who previously attended with a very rare ear condition called a Canal Cholesteatoma, and I'll explain what that is in a moment. It's probably around 6 months ago, and so we couldn't see the Canal Cholesteatoma at first instance, and we had to clean the ear out, and I then noticed the Canal Cholesteatoma, and we referred the patient onwards to see an ENT specialist, and they went to see a local ENT specialist, and ideally they wanted to operate on the patient because the canal cholesteatoma was quite deep and embedded, but because of the patient's age and other health issues, they weren't able to perform a surgery on her because she was not able to have a general anaesthetic. As such, the patient visited the ENT consultant almost on a weekly basis over a month or two, and the ENT surgeon applied loads of antibiotics topically via cream and some other steroid creams, and constantly just meticulously cleaning the ear out, trying to soften this hardened cholesteatoma. And after a couple of months of repeated treatment, the surgeon was able to overcome the canal cholesteatoma and get the ear infection free. But the surgeon did advise the patient, because of the crater created by the canal cholesteatoma, that they would need to have their ears cleaned on a regular basis, because having that crater will promote the buildup of dead skin keratin, as it has today. So the patient, consultant advised the patient to tend to see myself every couple of months. I can give you a good clean, and if there's any sign of a canal cholesteatoma, obviously refer back for further treatment. So they attended with a blocked right ear, and you can see all this is not earwax, it's dead skin. So let me explain what a cholesteatoma is in general, because there's two types, and I explain what specifically a canal cholesteatoma is. So a cholesteatoma is a buildup of dead skin, more specifically squamous keratinous skin. So the skin that lines the ear canal, as it dies and sheds, it should naturally migrate out of the ear. And when a skin cell sheds, it's almost like a fish scale. It's got that appearance. And that's the phrase desquamous. Squamous means like actually, I think in Latin it actually translates to a fish scale. And desquamous is when this skin has shedded. And so these skin cells that die, that look like fish scales, they should naturally migrate out of the ear, and that's because the skin in the ear canal has evolved to naturally move sideways, laterally, towards the entrance of the ear, like a conveyor belt. And that's our ear's method of self-cleansing itself. Unlike other parts of our body where we've got skin, so for example on our forehead, as the skin dies and sheds and is replaced by another layer of skin, the skin on our forehead will fall off onto the floor, either when we're washing or through drying our forehead after a bath. But our ear, if the ear just allowed itself to fill itself with dead skin, then everyone's ears would be full of dead skin all the time. They won't be able to hear and they'll get infected. So that's why the ear has evolved to naturally shed and expel the dead skin out of the ear. Now, what can happen in some people is, particularly people with a blocked Eustachian tube. So a Eustachian tube is a narrow tube that connects the middle ear. So the middle ear is the cavity behind the eardrum to the back of the nose, and more specifically the nasopharynx. And the Eustachian tube is the pressure equalizer. We want the air pressure behind the eardrum to be the same as the air pressure in the ear canal and the atmosphere. When the air pressure is equal either side of the eardrum, that's when the eardrum is most mobile and therefore vibrates the most in response to sound, allowing us to hear the best. So it's the job and function of the Eustachian tube to equalize the air pressure. Now, the Eustachian tube is typically shut. So this tube that connects the back of the eardrum to the back of the nose, it's typically shut at the back of the nose. And during the course of the day, without us even knowing, when we swallow, yawn or chew, it temporarily, momentarily opens, and the air pressure can equalise. And it's also a drainage tube, so any fluid that accumulates behind your eardrum, it can drain away. If you have a blocked Eustachian tube, however, so it doesn't open when it should, so when you're swallowing, yawning or chewing, the Eustachian tube is blocked, whether it's anatomically, you've got a very small Eustachian tube, or the congestion there, inflammation or an obstruction at the back of your nose. If that Eustachian tube doesn't open and is not able to equalise the air pressure, all the remaining air in the middle ear gets absorbed by the cells in the middle ear. So there's a shortage of air, there's no more airless, it creates a vacuum. And when you get a vacuum behind the eardrum gets pulled inwards, it gets sucked in like you're on a plane. And typically, it normally gets sucked in the top region called the attic. And when the top part of the eardrum gets sucked in, it creates a little pocket. And that pocket can then build up with dead skin. So the skin that dies and sheds, it gets trapped in this pocket and it can't move any further out of the ear. It just gets trapped. And this skin eventually gets infected and forms a plug. And then it can go inwards through the eardrum and towards, not only upwards towards the brain, but further into the ear where the organ of balance is, the facial nerve. It can go to the bone behind the ear canal called the mastoid. And it can also grow outwards into the ear canal itself. And we call that a cholesteatoma, and that can be life-threatening. If not treated, it can lead to meningitis, a brain abscess, so it needs to be treated. So that's what a cholesteatoma is. It's a buildup of desquamulated skin cells in the ear that can't shed, and it typically occurs in the top part of the eardrum in response to an eardrum that's been sucked and buckled inwards because of a blocked Eustachian tube. So that's the most common form of a cholesteatoma, and even that's quite a rare thing to see. But this patient has got a canal cholesteatoma, so the concept is very similar, but the location is different, and obviously it's given away by the name. So it's far, far rarer than a normal cholesteatoma. And in a case of a canal cholesteatoma, as the skin is shedding and migrating out of the ear, at some point or at some multiple points within the ear canal, normally when there's a little divot or a little cave or a little trench in the ear, the skin cells falls into the little divot, the little bump in the ear canal, and it can't come back out. I always call it a well almost. You've got a well within the ear canal and the skin drops into the well and it can't escape. And then that skin itself gets infected. And similar to a normal canal cholesteatoma, it falls into a plug. And when the skin gets infected, the keratin can become hardened or webbed. It can be one or the other. And it can start eroding the bone that surrounds the ear canal called the temporal bone. And that bone can then get infected, and this infection can spread towards the jaw, to the back of the ear, the mastoid, and again, upwards towards the skull. So again, it can be really, really dangerous. And it's quite a rare thing, but I'm seeing many, many cases of this now. And I was speaking to the local consultant who I refer the cases on, and they said that they've had so many referrals this year for myself. It's unbelievable. And so, because they're seeing more cases. So I'm not sure why that particularly is, but yeah, I'm seeing quite a few of these now. And so what's happened in this particular patient is that for some reason, the ear canal, there was a little trench or a little bump, a little dip in the ear canal, and the skin fell into there and it formed into a cholesteatoma, and it started eroding all the bone. And you'll see it in a moment now. You can see the top part of the eardrum, and all I've been doing, so I know I've not been talking much about the video, but all I've been doing is peeling away all this. This is all dead skin, layer after layer after layer. You can see now this skin is getting lighter in colour. Because this skin is fresher dead skin. It's dead skin, it is dead skin, but it's fresher, younger dead skin, so it's a lighter shade. As the longer the skin's in the ear, it oxidizes and it becomes darker in colour and almost black in appearance eventually. So I'm just using the fine end suction probe here, and you can see the eardrum there in the distance, and below that, it's almost like a cliff side. That cliff side is this patient's erosion. So the canal cholesteatoma was originally in this area, and it eroded and all the bone away. So you'll see all the exposed bone. Or where I am going now, This is the previous location of the canal cholesteatoma. And you can see the skin is already building back up. So that's why they need to come back regularly. This is about there was a bit more than 2 months, unfortunately, for the patient. But I'm just peeling away as much of this dead skin as possible. And I was happy to report that once I cleared it all away, there's no sign of a canal cholesteatoma there. It's successfully treated. And you can see I'm just circling it here. This is the erosion. This is behind all this. You'll see it. I'm going to clean up a bit more. That's the bone of the ear canal. It's fully exposed. You've got no skin on top of it. You've got no periosteum, which is like a buffer membrane between the skin that lines the ear canal and the bone. The periosteum is what supplies all the blood and nutrients to the bone and the skin. So again, you can be really careful because this is really it can be really uncomfortable for the patient because we're touching. If you're a bit aggressive, you're touching the bone, and that's why when I was doing the procedure, I was extremely delicate. The patient is quite an elderly patient, and they were in their wheelchair. Something else I mentioned, we weren't able to get them sat on our clinical chair, so I performed the procedure whilst they were sitting in their wheelchair. And that's what's great about an endoscope. It's really versatile and adaptable. We can get all different angles, and I came off my NT stool and I was on my knee a few times so we can get access and a good visual. So again, I'm just trying to peel this skin away. You can see that the top layer of the skin is quite crusty, and underneath you can see it's the fresher layer of skin. So it's more white and translucent. So this is more near the entrance, but I'm going to peel this now towards that cliff where the canal cholesteatoma was. So I know some of you are probably going to find this quite satisfying, this part, because of all the skin. And the patient's son and daughter-in-law were in attendance, and they could obviously see the screen when I was performing it, and they were just fascinated by how much stuff that we got out. So I'm just using the forceps here. I'm just trying to grip this. You can see a long tail of skin there. So there's no infection there. There's no hardened keratin. That's the important thing. The patient hasn't been able to go for a CT scan either because of their health conditions, and they're just not mobile enough to get a CT scan. And that's why the ENT surgeon did exactly the right thing, just on a regular basis, just saw the patient, kept cleaning their ear out as regularly as possible, and applied loads of antibiotic cream and steroids just to fight this canal cholesteatoma, to make sure it's not spreading any further. And after the treatment, the surgeon wrote to myself just to update me and explain that everything's ready to, given the all clear, and the patient will be visiting every 2 months now for their ears to be cleaned. Now, you're going to see some skin. We're not going to get every little aspect out. It's just not impossible. I just want to clear as much of this debris there as possible without making it uncomfortable for the patient. So it's kind of all the yellowy bits that I was really interested in, because that yellowy bits is skin that's been there for a while. It's keratinized. So this skin, as it dies, it loses all the intracellular fluid. So as we get older anyway, our skin becomes dry, and that's because the skin cells are not able to retain as much fluid as it was able to when it was younger. So it loses all the intracellular fluid, and it's replaced by a protein, keratin. So keratin's the same protein on our fingernails and hair. And you can see that this should not be here. This is like an underground basement. I think that's another good way of describing it. This should not be visible to the naked eye. It is because of the canal cholesteatoma, but this should all be bone, really, and we shouldn't be able to see this, but obviously the bone's been eroded and it's now exposed. So I'm going to go back, peel the skin away. Hopefully, I think I managed to do that. And there's a bit of skin right up against the cliff. I think I'm going to manage to get that as well. So this is all fresh layer of skin. A couple of times it was uncomfortable for the patient. They were also getting a gag reflex. So running at the base of the ear canal is a branch of the vagus nerve called the Arnold's nerve. And when you sometimes apply pressure in the ear, so sometimes when we take ear impressions for people that need swim plugs or ear defenders or hearing aids, it can stimulate this Arnold's nerve and elicit a gag reflex. So occasionally they developed a gag reflex. A couple of times it was also clarinetting as well, so we have to be careful. I think this bit was a bit uncomfortable for her there, so that's why I moved away. And I'm just going again right up against the cliff edge. And we're just touching, this is all bone, what we're touching now. And at the top here, this is some crusted, this is the skin that, what I've just lined. So below that should all be bone. Below that, that's the kind of the base of the ear canal. That's where the skin and ear canal once was. But below that is everything that's been eroded and is now visible. So I've just made a slight bend, as you can see, in the suction probe, just so I can get a bit more access into this bit. But I'm really pleased with this. There's no really dark yellowy skin there. So we're giving it a good clean. So you might just want to refresh if you're not sure where we started. So it's always good sometimes to go back to the beginning of the video so you can compare what the ear was like and what it is now. So before this canal cholesteatoma, there should have been bone all the way going upwards to above that skin level there. It was quite a big canal cholesteatoma, it was. So I'm just going just to the roof just to get this bit of skin there now. This is something that we're less concerned about because this is not skin that's going to fall into that widening erosion. So I think it was clarinetting, so I just decided to stop there. And you can see all this dry skin that she's got at the entrance. Well, I hope you enjoyed that video, and I hope the explanation made it quite clear what a canal cholesteatoma was, because it is quite a rare condition. And I've got loads more videos to upload in the next few days and weeks, so do stay tuned. Thank you, bye.